Hello, welcome back to Ground Yourself YouTube channel. Appreciate everyone tuning in. Appreciate everyone interacting. Continue to do so. This is a safe space for us to learn, to talk, to figure things out. Again, my name is Aixie. I'm a registered nurse, and I am about health, obviously, and wellness. I love skin and beauty, and amongst a few other things. So my channel will be geared to things around that type of content. Lately, I've been getting a lot of questions about adult family homes, how to start an adult family home, and a lot of questions, burning questions that people have been having. I'm going to say first, subscribe to my channel so you know when there's new videos that drop, and also like the videos. Let YouTube know and other people know that you like the content that I'm putting out there. Share the videos to people so other people can come across it. Maybe it helps somebody else out. So I'll leave it at that. We'll jump right into it. So a lot of people ask about rates. I feel like the managed care organizations create a lot of confusion around the rates, especially to the adult family homes, because their ultimate goal is to give you the minimum amount of money. And I personally feel that is a metrics that these care managers are. So that's my personal opinion. I have no proof to prove that is a fact. But I could definitely believe that right? Because every business, I don't care, at the end of the day, is all about managing their funds. And they try to teach employees how to minimize waste, right? I came across something yesterday. I was actually recording a video yesterday, and I forgot to turn my mic on, and oh my god, it was such a good video, and I was so hurt that none of the voiceover was recorded. But I came across, I'm back on here talking about this minimum rate thing, and I brought up the FAQs. And so I'm going over the FAQs about this new minimum rate, because I thought the minimum rate, because with Difference is My Choice, they make you come up, sign a contract with them for your base rate. And they try to keep you to that, no matter what level of care or acuity this person is at. And then they try to, only way that where you can get extra money is if they're a 1-on-1 or a 2-to-1 or a 3-to-1 and they have some type of behaviors. But that shouldn't just be the only thing that you grade somebody's level of care on, based off of their behaviors. Some people have very complex health issues. They don't really have behaviors, but their complexity of their health issues make them a tougher patient, because not only should I be having just CBRF certified people, I might need a CNA on that has more training. I might need to hire or contract with a registered nurse or LPN to be able to come do certain cares, right? I just feel like when base rate is just basically providing room and board. That's what these base rates are, is room and board. And then when you try to tell them, okay, this person needs, based on their care and supervision, they're like, well, your rate is what your rate is, and try to keep you there and argue with you about it and go back and forth with you about it. And it's like, you hit them with all these evidence-based, and me being a nurse, evidence-based arguments about why this person, why I need this to be able to care for this person. I can't sit up here and say that I'm providing the best and safest care to somebody who's bedbound, who needs every 2 hour turning, repositioning, feeding, and I have other people in the home. The type of level of care that I'm going to be providing to just this one person, just to be in the home, I need to be able to compensate for that. I need to be able to be competitive enough in this workforce to have staff for that. Especially, I'm not a live-in, and even if I was a live-in, I need to be compensated for that type of labor. And they've been getting away with murder, in my point. They really have. So when I got to reading this minimum rate stuff, right? And even I've done some of the webinars, and I never really went through like the FAQs and got to reading. I know at times I will get to reading, but at the end of the day, I always believe read, go through the fine print yourself, right? The webinars just kind of go over like a high level. They do try to answer your questions at that moment. Sometimes they're not the best answers, but they're helpful. I'll say that. But these, I don't recall any of this being in or being addressed. I don't know. Maybe I wasn't paying attention, but it is in FAQs. So what if my current rate is above the minimum rate? Providers will only receive an increase based on the minimum fee schedule if their current rate is below the minimum rates for their provider type and for the needs of the members they are serving. For providers currently paid above the minimum rate, MCOs continue to be contractually required to meet members' care needs, and that includes paying rates above the minimum when necessary. Okay? The family care contract includes the contractual requirements for room and board. The family care contract is found here. Let's go there. All right, so determining room and board obligation. The MCO determines the member's room and board obligation in the facility in which the member resides. Excuse me. Excluding members who reside in subsidized housing. MCOs must update member room and board obligations annually on February 1st or upon member's request. The member's room and board obligation is the lesser of the prior calendar year's HUD FMR rental amounts based on residential type by county, plus the primary calendar year's maximum supplemental nutrition assistance allocation for one person. HUD FMR amounts. HUD FMR rents are set at the 40% percentile of the surveyed rental costs, reflecting modest but reasonable housing, including utilities, vary by county and apartment size, and are updated yearly. And then it goes to saying SNAP allocation. The member's available income for room and board. All right. So let's go in here and see if it breaks down anything for room and board. The fair market rents are used to determine payment standard amounts for housing and for the Housing Choice Voucher Program. Initial renewal rents for some expiring project-based Section 8 contracts, initial rents for housing assistance payments, contracts in the moderate rehabilitation single room occupancy program. Well, yeah, I'm learning with y'all with some of this stuff. This system provides complete documentation of the development of the fiscal year 2025 fair market rent for any area of the country selected by the user. After selecting the desired geography, the user is provided a page containing a summary of how the fiscal year 2025 FMRs are developed and updated, starting with the formation of the FMR areas from the metropolitan core-based statistical areas as established by the Office of Management and Budget. All right, let's see here. Wisconsin. Milwaukee County. Okay. So are they trying to say it's 40% of this? So say for instance you have a 4-bedroom. That they are required to pay at least 40% of this $1,700? Is that what they're trying to say? I'm gonna have to read this, but if you know, if you get it, let me know. Put it in the chat, in the comments. Here we go. Base rent calculation. I'm gonna save this. I'm gonna read more about that. But yeah, I mean, definitely something to think about, you guys. Really think about that. Here we go. Captation, this is what I was looking for. Captation revenue shall not be considered a countable expense in developing MCO captation rates. Any MCO contribution to member room and board obligation from captation revenue shall not be considered a countable expense in MCO captation rates for each member who resides in community-based residential care as defined. This addendum. I'm going to figure out what this addendum is. Stuff like this, you guys, when you get to reading this stuff, copy it, research it, put it in the search bar. Understand, because these things right here, these little legal addendum and terms and things like that, these little things right here, when you're reading and going over stuff, hides the sauce, right? Hides the secret, whatever, right? So right here, HUD FMR amounts, HUD FMR rents are set at the 40% percentile of survey rental costs, reflecting modest but reasonable housing. Primary calendar head. The member's room and board obligation is the lesser of the prior calendar year's HUD FMR rental amounts. So if you say you have a 4-bedroom, I'm just trying to, and they had the FMR said it was about $1,700. What they're going to try to do is divide that by 4, so that's $425 a month for one person. Room and board, so it's divided by 30. So they're going to say that's like $14 a day. Plus room and board. Let's say room and board is $200. $200 divided by 30. It's $6.66 plus $14 a day. That's $20. Let's say just $21. $21 a day times 30. That's $630 per person just on room and board. That doesn't even make sense. You know what? If somebody knows and can break this down better, let me know. Maybe I can reach out and we can have like a discussion about this, a live discussion about this. And get to the bottom of this. Because this is like something that I'm still like confused about. And this is right here. This what right here is why I'm like, no, I don't want to be a consultant. Because if I can't explain this and be confident to explaining this and educating people that I'm consulting, I don't want to take your money. And that right there is why I'm like, no, not right now. Okay. We are back. I had to pause for a minute, y'all. All right, so let's get back to it. So we're still trying to get to the bottom of, and I think I kind of like left off saying that this is why right here, this is my main reason why I'm not ready to consult and take people's money to consult, because this is something I'm still learning, figuring out. And just to let you know, just because somebody's a registered nurse does not mean that they know this. You know, bedside nursing does not require you to know this stuff, right? You know, there's a lot of very smart, intelligent nurses. I think I'm one of them. However, this is a different type of healthcare. This is a different type of nursing. This administrative side, if you're, you know, mostly working in bedside, you don't really get to touch and learn this type of stuff unless you get into it and you specialize in it and you work in it, right? So here we are. So let's get back to it. So we're still trying to figure out this room and board stuff, right? So that I can help you guys understand room and board and what rates should be, how you guys need to be negotiating rates. What's a fair rate? Like, honestly, I feel like a fair rate. If they said that they wanted to give everybody one certain rate, I think a fair rate, you know, based off of, for most clients, if they don't need like some type of very, very special particular thing, or they're like really bad with behaviors and need to staff like 2 or 3 people onto one person, I think an average daily rate for people is $500 a day. If you can get 500, for sure, I'll say even minimum $400 to $500 a day on a client, you could be able to pay a decent living wage to staff members, to come into your home and work your adult family home. Be able to care, provide a decent household, food, and whatever needs, even transportation for these people. And then and still be able to be a business owner for you to make a profit, and run a successful business. That's what I think is fair. Just from what I see, calculating everything, that's what I think is a fair rate. But obviously, nothing is fair in this industry. So let's get back to it. Determining the member's available income. The MCO determines the amount of available income to the member has to pay for room and board using procedures specified by the department. Okay, the room and board obligation calculation is not prorated for partial months. MCO may calculate from the room and board from the member the room and board for actual days in the residence. Implementing contingencies if the member lacks funds for room and board. If the member lacks sufficient income available to pay room and board in the facility, MCO either develops an alternative plan of care to support the member's needs and outcomes. Determine amount contribution to a member's room and board obligation from captation. So captation, I'm gonna bring up the definition of what captation revenue is. Let me see. Matter of fact, while we're on it, shall not be considered a countable expense in developing MCO captation rates. And any MCO contribution to a member's room and board obligation from captation revenue should not be considered a countable expense in developing MCO's captation rates. Okay, so let's see here. Matter of fact, let me go to ChatGPT. Y'all, ChatGPT has literally been my friend. What's up, chat? I be talking to chat like we homies. Watch this. Hey there, not much, just here ready to help you out. How's your day going? It's going well now that I am talking to you. My best friend. Let's go friend room. Glad to hear that. I'm always here for you. What's on your mind today? All right, Chad. I'll get to the business at hand. Help me to better understand what captation rates are. And how does managed care organizations use them to determine room and board for members? Hopefully that wasn't a lot. Rates are a form of payment arranged in healthcare, particularly used by managed care organizations. Here's a breakdown of what they are and how they are used to determine room and board for members. All right. Definition. Capitation is a payment model where a healthcare provider is paid a fixed amount per patient for a specified period, regardless of the member or nature of services provided. This means that healthcare providers receive a set fee per member per month to manage the patient's care. Okay, so the capitation rate is what you as a provider is paid as a fixed amount regardless of whatever services are provided. So that's the rate. The purpose. The capitation model aims to incentivize providers to offer efficient and preventive care as they benefit financially by keeping patients healthy and avoiding unnecessary services. Determining room and board. MCOs use capitation rates to establish budgets for various services, including room and board in facilities like nursing homes or assisted living. So the managed care organizations also receive a rate per patient that they are providing care for, because they're also a provider. The rates are calculated based on factors like the demographics of the member population, historical health costs, and the types of services anticipated. Financial risk management. By using capitation, MCOs can manage fiscal risk. If healthcare costs exceed the capitation rate, the organization absorbs the loss. Conversely, if costs are lower, they retain the difference. Do y'all see that? Do y'all see that? I don't know if y'all ain't get it like how I got it, but like I said in the beginning, these managed care or care managers for these managed care organizations, they should know per person what their capitation rate, what they've been paid by the state or whoever per person, right? And they may know on average what that looks like for most of their clients that they are providing services for before they put them in the adult family home. And that's why they try to put you into these rates. These specified rates, talking about this is your base rate, this is your contractual rate, and that you will accept any and every person based on this rate, no matter what services you provide. Okay? So, and then whatever services are not used or absorbed, like if they anything retained, they retain the difference if the cost for caring for these people are lower. And they're trying to provide a lower cost for these people and making the adult family homes eat that cost to take care of these people, and they're not eating the cost. They're making the adult family small business owners absorb that cost, and that is not right. That is what they're doing. Let me calm down. This creates an incentive for managed care organizations to manage care effectively, focusing on preventative measures and efficient resource uses. I'm going to tell you right now, I've worked with a few different case managers. And I'm telling you, they done came out to the house and checked and did their little quarterly meetings and every 6-month meetings. They are not offering resources. If you're not bringing something up and asking them, they're not emailing, they're not in communication. And I don't know what their caseload looks like, but I guarantee you, they are not. As I feel like as long as you're quiet and not saying anything, that's good for them, because they're not focusing on preventative measures. Okay? Resource allocation. Capitation rates help managed care organizations allocate resources more effectively by predicting the total expected cost of care. This allows them to set aside appropriate funds for room and board expenses. Contracting with providers. Managed care organizations often contract with providers, such as nursing facilities, at predetermined capitation rates, ensuring that these facilities receive a consistent income while the managed care organization manages overall patient care. So basically, to me, what this is saying right here is that if they put you in the nursing facility, and the nursing facility has set up your contracted rate, your capitation rate, ensuring that the facilities receive a consistent income, while the managed care organization, okay, which means My Choice, Community Care, Inclusa, iCare, Molina, is supposed to manage their overall patient care. So really, I'm just supposed to be, it just really seems like you're just supposed to be housing them. And that's it. And that's fine if that's all that I'm doing. That means you, the RN and the case manager and all that, needs to be managing the patient care. Patient care means making sure meds are getting passed, making sure their functions, or you're assisting them with their functional needs. Oh my God, like the list goes on. How is the managed care organization doing that? By allowing the adult family homes to do that, but then you're not paying them. You're not incentivizing us to do that. You're not paying us to do that. You're like, well, you know what the issue is. No, you know what the issue is. I digress. This is just capitation rates, influencing capitation rates. In conclusion, in summary, capitation rates are essential for management organization in managing costs, promoting efficient care, and determining budgets for services like room and board. Understanding these rates can provide insight into how healthcare financing operates within managed care systems. If you have any more questions, you know what? Thank you, chat. Thank you, chat. You are the best. All right. So let's get back to it, y'all. Let's see here. MCO determines the amount of available income the member has to pay for the room and board, blah, blah, blah. The member lacks sufficient income, blah, 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 may contribute the member's payment to the facility. MCO may use its discretion to determine the amount to contribute to the member's room and board obligation. Any MCO contribution to a member's room and board obligation for capitation revenue shall not be considered a countable expense in developing MCO's capitation rates. Collecting and giving the member's room and board obligation to the residential facility. The management organization shall collect the member's room and board obligation. So if people have SSI and things like that, and they're under income, if they're going to be on family care, that MCO is going to take their money. That money gets paid to the MCO. And the MCO pays out, obviously, whatever your rate is for them to stay there and live there. And give it to the residential facility on behalf of the member. What? The MCO shall collect the members. I got a question then. I'm gonna have to reach out to one of these contractors. Collecting and giving the members' room and board obligation to the residential facility. The MCO shall collect the members' room and board obligation. So if their obligation is turning in their Social Security, they take over their Social Security and give it to the residential facility on behalf of the member. And then would they be given that? Does that mean that? Or you just get whatever your contracted rate is? Upon request, MCO shall disclose the monthly amount attributable to services and supervision to the residential provider. MCO shall inform the income maintenance agency of the room portion of the member's room and board obligation. The room portion is always the member's obligation minus the maximum SNAP allocation, which is the board portion. That information may be used by income maintenance to determine any available excess housing costs that may reduce the member's cost share. The room portion is always the member's obligation minus the maximum SNAP allocation, which is the board portion. That information may be used by... You know what? I'm going to see if I can get my hand on somebody's contract. And I'm going to read it, and I'm going to have to redact some things and compare that to what the state of Wisconsin says is required. So, okay, y'all, let's continue. So, they're sending out amended contracts. So, if you're already a adult family home owner, if you haven't received it, I think they have to the end of this month, end of December, to get things out and signed. Will we be given more responsibilities as providers in the new contracts? The minimum fee schedule should not change responsibilities under the contract. Okay. corporate 1 to 2 bed adult family home follow the tiered schedule. What about owner occupied 1 to 2 bed adult family homes? The minimum payment rates for owner occupied 1 to 2 bed adult family homes are to be no less than the equivalent of the 15-minute MCO Director Supportive Home Care minimum payment rate, which is $6.38 per 15 minutes, multiplied by 15-minute units of time needed to provide care and active supervision to the member as specified in their plan of care. Okay. So that's something different. So somebody's a diabetic and, you know, I believe testing supplies are not covered under these, like these Medicare and Medicaid insurances. They're not covered. All right, let's go back up really quick. I feel like we passed some of the stuff. Okay, right now, care and supervision. So that we know these minimum rates that they put up here. These do not include room and board. These rates right here are only for care and supervision. Do minimum rates include room and board? No, minimum rates are only for care and supervision. Care and supervision. Okay? So, which means that the managed care organizations still need to include room and board into these rates per person. Right now, care and supervision are bundled with room and board for a single resident rate from the managed care organizations. Will these now be separated? The minimum fee schedule does not require managed care organizations to separate care and supervision from room and board. Managed care organizations can still pay a single residential rate. Managed care organizations may also choose to unbundle room and board from care and supervision. So basically saying they could still say this person, this is their single rate on the contract. They don't have to separate it. But do know that they still at minimum will have to be paying, not even at minimum, that if they offer you one of these rates here, that is only for care and supervision. That does not include their room and board, and you fight against that. You fight against that if you're getting a contract. If they still trying to come, when you're trying to become a new provider and they trying to hit you with a contract and try to say, oh, your daily rate is going to be $238.08, you're going to say no. Based off of this information here, that is a minimum rate for care and supervision. That does not include my room and board. My room and board is XYZ. And this is how you're going to determine your room and board. And I'm going to save this and put this into a link so you guys can download this and get a good idea of what it costs to run your business monthly and yearly. So I got my hands on this. And you're going to put in here, and these are annual numbers. So you want to put how much rent and mortgage payments plus insurance that you pay a year. And these are just made up numbers, you guys. But I try to make them as accurate or realistic as possible, right? Building and grounds maintenance, food cost, household, furnishings, right? You put in everything that you are paying, right? If you own your home, you're paying property taxes. If you're renting, you're not paying property taxes. I don't know what you're doing, but whatever you're paying to manage your house and your home, you're gonna put that in there, right? Based off of how many bedrooms. Now for this right here, I like to put, this is very important. I'm gonna highlight this: number of persons living in the household include all adults and children. Now, if you have a 4-bedroom, you will put 4, right? They want you to put 4. So let's say your room and board would be $46 a day per person. And see, $46 a day times 30 would be about $1,300. Let's say $1,400 a month per person just for room and board. All right. If you have, now this is what I like to do. I like to put it at the one person. I like to put it at the one person because honestly, you don't know who you're going to be getting for them people when them people coming in there. And you want to be able to over budget your expenses a little bit because you have to plan for unexpected expenses. My thoughts, personally, I don't have a business background degree. I have a science and nursing background degree. But I think anybody doesn't need a business degree to understand that you have unexpected expenses. We have unexpected expenses in our regular day-to-day life, right? So you always try to plan to save for unexpected expenses. So that's what I would fight for my room and board rate to be $183 a day per person. That has you about $5,500 a month just for room and board, right? But let's say, okay, we stick to the plan. If you have a 3 to 4 bed, let's go. Okay, a 3-bedroom is $61 a day. Times 30, so it's $1,800, a little over $1,800 a month. Okay, say for instance you have a tier 3 person, and I'll try to find what these different tiers, what they are. Okay, 238.8 times 30. That's a little over $7,100 a month. What we say, plus $1,400, so it's about $8,500 a month for this tier 3 person if they try to keep you at that, right? 61 plus 238.8 is about, let's say, $300 a day. So, you know, $8,000. Let's just do the math. $8,000. If you have 3 people, that's $24,000 a month. Times 12, that's $288,000 a year. All right. So that's what you know out of a year. Right here, you're, let's say here, $288,000 for a 3-bedroom. If you're getting $8,000 a person, you should track the 60, let's say $67,000. So you're left with $22,221 out the year. Right? Now, you still got staff you gotta pay. Salaries. I budget my salaries. I try to be what's compatible but reasonable. Anywhere between $20 to $25 an hour. Especially for in healthcare, CNAs are making minimum 20 plus an hour. Some of these CNAs are making like nurse money, okay? I'm not mad at that. Get your money. Boo. CNAs have been very unappreciated, underpaid for a long time. I just want my CNAs to be a little bit more professional. That's all I ask. Just be a little bit more professional. You know, when you go into a hospital, if you have family members, you want to be treated a certain way. So don't get into these jobs and then be comfortable and you lower your expectations on professionalism because you tired, you young, maintain professional. Let's bring professionalism back. That's what I want for 2025. Bring professionalism back. I went to McDonald's the other day and no, good morning. And my McDonald's was my first job. Okay, you could not be behind the counter and not be smiling. And I didn't want to. You could be having a bad day. You better be smiling behind that counter. What? Not say good morning to a customer coming through drive-through or just wherever. Hello, good morning. Oh, they're gonna tell you. They're gonna put you to the side and talk to you. I know you have. They want to, because McDonald's food is not top tier food, so they pushed. At least when I was working, 10 years ago in the 1900s, it was about customer service. It was about professionalism. You created an experience. Healthcare is and should be the same thing, because we can't fix everything for you. But you create a healing experience, and that right there helps people to be able to move forward from whatever they're going through, because you're creating a healthy environment, a healthy and healing environment for them. So that's all I'm going to say about the CNAs. I'm giving some great CNAs out there, and I appreciate each and every CNA that are out there, because you are part of the nursing staff. You are a nurse. You are a nurse's assistant. And we need to work together for one common reason. Whoever your patient is, whatever you're doing for at that moment for that person. So definitely appreciate and much shout out to all the CNAs out there. Do your thing. But okay. So you need to be competitive, because you're not going to get anybody reliable trying to pay them $10, $12 an hour. You're not even the CBRF certified people. You're not. So again, you're already in a negative, because after you paid your just expenses for maintaining the house with the $8,000, and if you have all rooms full with this tier 3 person, after paying your yearly expenses for room and board, maintaining the home, you are at $221,000. And now you have to pay what covers care and supervision. And that right here, for my home here, not my real home, but my fictitious adult family home here, we're going to put 3 beds, is so yearly cost of $269,000. I'm already in the red, right? About $40,000. Just for the staffing and the level of, to provide the level of care. So if my room and board is $61 a day, room and board for what I put in for my expenses for staffing and all that, for care, to provide care and supervision, we're just gonna say $247. So $308 a day you need to be getting to just break even. Times 30. So each person needs to be bringing about, it says 9. So if you add what you calculated, your $246.12 plus $61 a day, at minimum you need to be getting $9,240 per person per bedroom. So we're gonna divide times that by 3. So that's $27,720. And I hope I am not confusing people, talking in circles. So $27,000, a little over 20. We'll just say $28,000 a month times 12 is a year. So this will put you at $336,000 a year if you get a rate based off of your expense report here. So in this expense report, you need to be calculating what your payroll is going to be as an owner. Do not look at it as you calculated all your employees' payroll, and you calculated the RN's payroll, and you calculated federal tax, work tax, unemployment, insurance, education, all that, right? And you didn't calculate what you want to bring home for yourself for running your business. Because you are an employee too. You can't take the money out of the business account and live off of it and not show that, technically show that you are living, you know what I'm saying, how, you know, your income. You have to put in your income so that you know when you start cutting yourself checks, you're getting what you need so that you can live, right? So I think people forget that. People forget to calculate in here what your salary is going to be, it takes for you to live, right? The checks you gonna need to be cutting yourself. But I don't. So, long story short. So yeah. So if you're getting $28,000 a month, if you have all bedrooms full, for the year $336, we know $269,000 of that was going to go to staffing and things like that, running the business, and the other $66,000 or so is going to be for room and board, household stuff. So yeah, these are numbers I just kind of put in there, and I didn't even think because I don't even think I added anything in here as far as adding. I might even do it more because administratively you might need to contract with a registered nurse. So say for instance you give a registered nurse $1,000 a month. I'm just saying that they might want more. I don't know, $1,000 a month. So it's $12,000 a year. So let's say $14,500, whatever I add on there. Administrative overhead, if you want to put in maybe whatever you want your income to be. Let's just say you want to at least take home, I don't know, you guys, $50,000 a year from this home for your business. So, and you're running and working your business. So let's add this. So it's 64, just say 65,000, you guys. So that would be $303 to be able to cover those costs in payment. This is what your rate would be that you'll be fighting for care and supervision. Room and board would be this. You'll be fighting for this. Because minimum, you're going to be getting one of these three rates. So if the managed care organization, like it says here, decides not to separate, and still when you sign your contract, and they're going to be trying to get you at the capitation rate, right? Trying to get you at a capitation rate, which says your adult family home based off of whatever patient you get, for the most part, unless there's some type of behavior need extra, one-on-one, two-to-one, whatever. You need to be able to fight for your base rate, for lack of a better term, your base rate to be whatever this is going to be, whatever you calculate here, to be on that contract, so that at minimum you will be at least getting this to be able to cover costs per person if they push back and don't give you any extra money when you try to fight for extra money based off of whatever type of person they're trying to put in your home. How does a residential provider calculate the full amount they will receive from a managed care organization under the minimum fee schedule? The minimum rates are only for care and supervision. Managed care organizations are required to calculate every member's room and board obligation, collect this obligation, and give it to the residential facility on behalf of the member. Never seen that they did that. Never. So you're going to have to ask for that. Room and board is not a Medicaid coverable expense, and managed care organizations are not required to supplement room and board payments. So that is why Adelphia Homes, so Medicaid is covering, if you're getting payments from the government, but it's HCBS, home community based services. You're providing a home community based service. Medicaid is taking it over. And what they're basically saying is room and board, paying for somebody's room and board, their living, is not a covered service that they offer or that they pay for. And that the managed care organization is responsible for that. And it says, and managed care organizations are not required to supplement room and board payments. In these cases, the provider's total funding from the managed care organization would be at least the total of the minimum rate plus the member's room and board obligation. DHS will be enforcing the minimum fee schedule by monitoring that managed care organizations are paying at paying at least that amount. So basically, again, when you're getting people, you need to know, start asking them, and don't be afraid to ask them. This is your business. What is the room and board rate for this person that you're paying? So when you're contract, you should have a contract specialist. Reach out to them. I need to know the room and board rate for this person, because this is what it costs for my room and board for them to be here, for me to maintain my home. At minimum, care and then you go over their referral. You see what type of level of care that they need. You see where they're at on the tier schedule, what kind of services, and I'll try to find that really quick before I end this video. Real quick here, how will this impact IRIS, Include Response I Self-Direct Program? The minimum fee schedule does not apply to IRIS. IRIS participants negotiate their own rates within their budget. I see a lot of people going to IRIS, but IRIS does not see any referrals. You gotta find your own people. This is a really good question, because this happens all the time, y'all. Sometimes what is reflected on the adult long-term care functional screens when they see the referral of the person is not how a person functions once they have moved into the facility. How can this be addressed? Managed care organizations continue to be contractually required to meet members' care needs, and that includes paying rates above the minimum when necessary. Providers can negotiate with managed care organizations as they do today if the members' needs, which they don't, they do not. If the members' needs on the functional screen do not fully capture the members' care needs. Further, providers can work with their contracted managed care organization if they believe the functional screen has not been completed accurately. So really good information here, guys. Like really good. Like dig into it, read it, read it. I'm gonna reach out to this person here. I want to reach out to this Nicole Pagliaro. I'm gonna send her an email. I'll do another video about the email that I sent to her, trying to get some of these questions answered about determining room and board. Are they separating room and board? Are they still, when they send out new contracts? How all that goes. And I'm going to share that information with you guys. Or email her yourself. Email her yourself with your questions. You know what I'm saying? Definitely. Don't wait around for me. Obviously, still, tune in. Great. I can be an added resource for you guys. But don't wait around for me. Reach out to these people. I don't want to waste no more time, but I might go look into these right here. I'll put these link in here too. This is like a lot of really good information. And it just, I have a background. I worked as an MDS nurse. MDS nurses is a acronym for minimal data set nursing. And basically, MDS nurse, they'll work in like these long-term care facilities, and they're basically the reason how well a facility is getting reimbursed or paid back, right? So the MDS nurse does quarterly and annual assessments on people in the nursing homes or the skilled facilities, and they submit assessments to CMS, which is Medicare, and you reflect on, you go through like all these functions and everything, and you kind of report like what health issues this person is having, like their barriers, where they're functioning at, the type of level of care that they're receiving, right? And you do these assessments and they're submitted, and so within that 3-month period, based off of, they have different levels, right? Like extensive services, special care high, special care low, basic care, like it's just different levels, and based off of that, you're able to calculate what this person's daily rate would be, right? And sometimes it can be higher than whatever they have a contract with community care, managed care organization, and managed care, they're only going to pay so much, right? Especially if they're on Title 19, they're only going to get so much. You could get whatever the max is, but you're only going to get so much, right? You just be a set rate, whatever that is. And that's why there aren't nursing homes like it used to be, right? Old people go in nursing homes, like they're sending people back to the homes, because now these nursing homes are only allowing rooms, a certain amount of rooms for these Title 19 people to house these Title 19 people, right? And the goal, obviously, for the common person is, you work all your life for retirement, right? And you want to be able to give some of that money, and you transfer that money to your loved ones, your kids and stuff, right? So they can continue and build generational wealth and whatever, right? Not to pay it to a nursing home for all the rest of your life, right? And get bleeded dry by that. So the goal for most people who financially know is, you either, so for the state of Wisconsin, they do a 5-year look back period into your finances for you to try to qualify for Title 19, to get on Title 19 family care or whatever, so that the state will pay for your living. And so people who know and start planning things out before their health gets really bad, they either put things in a trust, or they start transferring homes and whatever else, accounts and stuff, out of their name, to protect their finances, so that they can then apply for Title 19. Because if you're over like the income threshold, which I think is like $2,000, you have to spend down. And majority of the time, that spending down is like you paying your money. You're paying whatever that daily rate for a nursing home is, $700 some a day, until all your money is gone. Then once you get down to that level, then you finally, once they drain you dry of all your money, Then they put you in, then you can qualify or apply for Title 19 and get Medicaid and whatever else. And then they'll get the minimum rate. So that's why once that happens, that's why now, because nursing homes are not making money with these people living for whatever, how long in these nursing homes, only getting the whatever minimum payment that they were going to get from Title 19 and Medicaid. And they start changing into skilled facilities, and you have more skilled nursing. Because even in nursing homes, you were still doing skilled stuff, but you have to pay nurses, you have to all that. So like now they're allocating more rooms and beds for patients who need subacute services. So subacute means below acute, right? So acute is usually hospital level care, right? You're in an acute setting, and that's in your hospital, your med-surg floors, right? And once you're at a level where they say, you know what, you're not acute anymore, you can go to a subacute facility, which is a skilled nursing facility, aka nursing home. And you go there, you continue whatever antibiotics for however many more weeks, so you can work with physical therapy there. And till you get to a point, then you can either transition to go home, or you're transitioning long term, right? So they have more beds now catering to skilled facilities, skilled nursing, because they're going to get more money, right? So skilled nursing is 100 days. Now, that's a whole nother story. I'm not going to get all into that. But they have 100 days where they can get way more money and maximize their profits than taking and housing people on Title 19, elderly people for like nursing home. So that's where adult family homes are starting to be growing and coming into play, because they're sending these people back out into the community, because they're like, well, we can't keep them, we don't want them, we're not getting, and especially if they have too much care and they're only getting minimum Title 19 Medicaid payment benefits, or if they can't reskill these people for some reason to get a higher pay rate on them, they're kicking them out, they're sending them back out to the community. So the only good thing about this, I see opportunity as NDS nurse, like if they do this and Medicaid is taking over, and again, these are minimum rates, meaning they're minimum, there's always a maximum. I definitely see opportunity if it goes into structuring rates and payments like how the nursing homes is, an opportunity where adult family homes may need an NDS nurse to make sure and calculate and do billing and coding and claims like that to maximize their rate payment. But again, I'm not saying that's what it is. This is just me like forecasting, thinking out loud, just from experience of what I have seen, what it's looking like. I don't know. I was trying to find. And again, if you already, even though you're licensed and already certified, you have to re-enroll into the Wisconsin Medicaid program. You have to be able to get your Medicaid, like whatever, be able to operate to receive the Medicaid services. All right, y'all. I'm gonna end this here. This is a lot of good information we went over. Let me see here. It's powerful. I just really wanted to try to see if I ended. Oh, here we go. Tiers. Here we go. Tier. So acuity. Anybody who's not in healthcare. Acuity means basically like we level how bad or how much care a needed person takes by their acuity. And acuity just basically means how much care this person needs. And if they're acuity 1, they're at a lower level. Acuity 2, they're like moderate, right? Acuity 3, they are like, they need a lot of care. They need a lot of like supervision, monitoring. They're not critical, but they're up there, right? You got to do a lot of work with them. You're going to spend a lot of time with this person. Okay. All right. So there are 3 tiers for corporate 1 and 2 bed adult family homes, 3 to 4 bed adult family homes, and CBRFs. Okay. Tiers are member specified and based on long-term care functional screenings. Member tiers are automatically calculated using the LTC of the long-term care functional screening. Basically, members are assigned to the highest tier they qualify for it. Right? Members only need one from a tier to qualify for that tier. Right? They don't need multiple. They don't need to meet all the like bullet points in the tier. They just need to meet one and they will be in that tier. All right, members that do not have needs listed in tier 2 or 3 are assigned to tier 1. Tiers correspond to a minimum rate that a provider must be paid. Minimum, the keyword is minimum. All right. Wondering 2. For tier 3 patients, right? They are going to be wanderers at night, day, and night. Injurious behavior. Self-injurious behaviors require intensive one-on-one interventions more than 2 times each day. All right? Banging their head, banging on themselves, whatever. Offensive or violent behavior. Offensive, violent behaviors that require intensive one-on-one interventions more than 2 times each day. And that could be a number of anything. Uses a mechanical lift, not a lift chair selected in transferring ADL. Not a lift chair. So mechanical lift, Hoyer. They need a Hoyer. Tracheostomy care. They have a trach. Tube feeding. If they have a tube feeding, PEG. Positioning in bed or wheelchair every 2 to 3 hours. Selection is any of the following. So again, what I say. How can you pay and stick me at saying, well, this is your base rate, and the level of care you have to be paying also based on care, which I like this. I like it. I just hope that it doesn't with centralizing. I just have an issue with centralizing because when you centralize, you take out competition, and when you take out competition, then people are not going to be able to. They can use that against people, especially like small businesses and things like that. They can use that against us, right? And it's basically put them into a monopoly where they're like, take it or leave it, and that's that. And where you have no choice, you can't go nowhere else because no one else is doing it. There's no competition. Okay, but I like it because again, it gives the adult home the ability to argue. This is the type of care we need to be, because when we argue care, they're like they don't even care about the type of care. They be behavioral. We don't documentation on behavior. So okay, a tier 2 wandering, daytime wandering but sleeps at night. All right, so that's the difference between tier 3. So tier 3 wandering is wanders at night or day and night. Tier 2 wandering is daytime wandering but sleeps at night. Self-injurious behavior. Self-injurious behaviors require interventions 2 to 6 times. Tier 3 is require one-on-one interventions more than 2 times each day. All right. Offensive, violent behaviors 2 to 6 times per week. Oh, that's 2 to 6 times per week. 1 to 2 times per day, or 1 to 2 times per day. 2 times. So okay, this is the big difference. So for both of these, they're at least doing it 2 times plus each day. Dressing. They need help dressing. They need help with supervision, cueing, hands-on assistance. Needed helper must be present. Toileting. They didn't have dressing over here, but okay. Toileting. Help, supervision, cueing, hands-on assistance. Needed helper must be present. Transferring. Needed help must be present. Ostomy. Related skill services selection is any of the following. Whether if they're independent, you change it 1 to 3 times a month, weekly, so if they have an ostomy is any hole in the body where waste comes out, right? Not a tube feeding, where waste comes out. So you have an a suprapubic catheter, and that creates the ostomy and a hole in the bladder through your stomach where urine will come out through the catheter. A nephrostomy tube. A nephrostomy tube is usually you'll see it in the back, and that comes out of the kidney, and urine or fluids and stuff and waste will come out into a bag, or they can have it capped off. However, they need to decompress the kidney, or if there's some type of calculus kidney stone that's obstructing for urine to go through, it'll come out the nephrostomy tube in the back. Ileostomy usually be in the stomach, and that's coming out outside of the colon. So, and usually ileostomy is poop, but it's usually more in a liquid form because the part of the intestine that it goes into doesn't get a chance to form as a full, like a stool. And then you have your colostomy, where the ostomy is from the colon, and the poop usually comes out for the most part formed in like poop. So, it, for whatever any obstruction or any other disease reason that the person is not able to defecate from their butt, it's going to come out into the colostomy bag, and that you will usually see that in their stomach area. So those are what ostomies are. So if someone has a catheter, like an indwelling catheter, either going into their vagina or their penis, those are not ostomies. Those are not ostomies. They're just indwelling catheters because there wasn't a hole created in the body. Okay. Tier 2, no wondering, no self-interest behaviors. Self-interest behaviors. Some self-interest behaviors require interventions weekly or less. Offensive or violent behaviors, none. Offensive or violent behavior to others. Some offensive or violent behaviors that require interventions weekly or less. All right. So these are the rates. Minimum rates are effective as of October 1st. Retro payments begin no later than December 31st. So if you're billing at whatever your contract is, they're supposed to be giving you a retro payment. But the managed care organizations have until, again, December 31st to send you a new contract for you to sign. I'm not going to continue into this. Again, this is the slide. Go in here. They have a pre-recorded recording. Educate yourself. Educate yourself. I will, again, drop the links in the comments. Feel free to comment. Add your thoughts on this video. Listen here. We are here to learn. We are here to figure this thing out together and be successful, you guys. We are going to be successful. I believe it. You have to believe it. When you're reading this stuff, change your mindset. Change your mindset, right? If this is something you want to do, find some passion in it. Find passion in it and go through it. That's the only way. When I first started going to nursing school, I used to dread it, right? Because I'm like, oh, I gotta do all this reading, da 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 da, and I used to complain about it. And I don't know if y'all remember that juice bar, that black juice bar, the first black juice bar on North Avenue. I forgot their names. I forgot what it was called. It was over on like 18th or 20th in North Avenue, right? Over in that what's the neighborhood over there? I can't think of it. But it's a husband and wife, black husband and wife, great people. And I used to know the names. I can't believe I forgot. But anywho, I used to go over there. And when I started nursing, I used to get me my little juices, right? Being healthy, starting my day off right. And I came across, and people was just in there when they're with their juices and have great conversations and enlightening conversations. And I was talking, and they're like, somebody, and I'm like telling them, like, they're like, oh, where you going and stuff. I'm like, oh, I'm a nurse, and I'm going to nursing school. I'm like, I'm struggling right now. I think I was in chemistry. Like, I was taking a chemistry class. No, I was taking microbiology. Taking microbiology. And I was struggling. I'm like, oh my God, I have to read all this because usually, like, instructors, they would like, they would put, based off of their PowerPoints and stuff, you can like tailor like their lesson plan and study from that, right? You really didn't have to crack open your book. But this instructor, like his lesson plans and what we talked about were nothing similar to what his testing was, right? So after like I think the first test or so, like everybody like failed miserably. I mean, failed, right? And then the second test, I think I failed, but I didn't do too bad. But I still failed. I'm like, what is going on? So I just like, you know what? I'm gonna have to read the chapters that we're going over. I can't rely on like my study notes with him, what we're talking about in class. I can't rely on these PowerPoints because I'm studying these PowerPoint stuff, and like when we got the test, we're like, there's nothing in this PowerPoint. So I just used to break down my reading, y'all. Like I used to like schedule my day and hours. Like I'm gonna read this chapter. By tomorrow I'm gonna read this chapter, and I would like. And then I started passing, and I was like the only one passing my exams, y'all, in this chemistry class. But I used to complain about it, and I came across this black lady, and I'm like telling her about it and complaining, and she was like, "What? That's so interesting! Oh my God! Like, she's like, you gotta change your mindset. Like, if this is something you want to get into and you're passionate about it, like, you have to start finding something interesting about what you're reading. Like, you have to make it fun." And I'm like, yeah. Oh my God, yeah. Like, right. Like, that makes so much sense, right? And it's hard changing your mindset, but you have to. And I'm not gonna make it seem like it was easy, but I did. I started working on changing my mindset behind the stuff that I was reading. And don't get me wrong, like science and math has always been my strong suit. Just growing up, like I've always been a math and science girl. So like I just never really liked writing and reading because of just like too much. I just like doing stuff with my hands and figuring things out. I like to be very black and white. Very always just very black and white. Growing up and getting straight to the point. So for me, like reading took out time because I'm like I'm just anxious. I need to get to the bottom of it. So I just started changing my mindset about it, and that's what you guys have to do. Like you have to start changing your mindset about reading some of this stuff. Like bring reading back. We said bring professionalism back. Bring reading back, y'all. Like it's imperative, right? Because how are you gonna know to ask the right questions, right? To be able to learn, to make changes, to do whatever if you don't educate yourself. Again, safe space. I'm here for y'all. Y'all here for me. We're gonna get through this together. Um, and let's get to the bottom of it. And let's 2025. We successful. We successful running adult family homes, right? Well, I don't want an adult family home, but helping people run adult family homes. Help. Listen, we're here. So again, like this video, subscribe to my channel, share, share, share